Prescott, and he was involved in some extensive phone calls this morning, and he missed the Sedona 179 turnoff. So his navigator told him to turn around and come back, and so he's working on it. When, after I finished my radiation treatments in July, I was thinking about what do I do next in my life that makes sense. And I discovered that there are 8 or 9 hospice organizations in northern Arizona. And I did a lot of investigation. I sent out 8 letters saying I was looking for something part-time. One executive wrote back and oohed and awed over the stationery I used, which was just professional cotton bond stationery. That interview was chaotic. I decided that was not my place. And so 2 out of the mailings I sent out came back. So that limited my prospects to 6. And I did a lot of investigation, and as I investigated, I discovered Maggie's Hospice, and it's headquartered in Prescott. And one of the things I discovered about Maggie's is it has a 5-star rating among its patients and consumers. So people who've used Maggie's have given Maggie's a 5-star rating, and that's well documented. The other thing that impressed me about Maggie's is when we've had inspections by Medicare, they've been deficiency-free. And having been through all kinds of inspections by DHS at Rainbow Acres, a deficiency-free evaluation is really, really a rare thing. And I found that to be true of Maggie's. So when it came time to interview with Maggie's, I was thrilled to have the opportunity, and I've been as thrilled since as I was the day I interviewed. And I'm really so I want to share those things as introductory remarks, so you know a little bit of why I'm so sold on Maggie's Hospice. Maggie's is I forget how old it is. I'll let Jason tell you. Jason just arrived. Would you like a cup of coffee? We can give you a cup of coffee.
I've got my liquid chemical here.
Okay, very good. So Jason, why don't you come on up? Jason has 2 support people, and they would be the people you would hear from when you call Maggie's and say, we're interested in hospice, can we talk to you? And I want to introduce Natalie and Jonelle. They're our admissions people, and they would be the first contact you would have after you make a call to Maggie's. Now, Jason has been, he's got his bachelor's of nursing, bachelor's of science nursing, and he's been in healthcare for a number of years, and he's been in hospice care for 15 years, and he was just promoted to Director of Clinical Services at Maggie's. And so, welcome.
How are you doing?
Good.
Sorry I was late, guys. I got a little turned around with the GPS this morning. How are you guys all doing this morning? Great. So Gary asked me to come and talk about some myths of hospice. So I've got a few talking points, but if there's questions you guys have, I'd love this to be more of an open discussion. So if there's things you guys want to learn about, maybe we'll end up touching on them here. The first myth that I hear people talk about a lot is that hospice is a place. A lot of people think that there's a nice home that you get moved to and that's where you're taken care of. That's most of the time not the case. There are a few facilities like that around here, not many. But oftentimes hospice happens in our homes. It can happen in assisted living homes if you know maybe you got friends that live at an assisted living facility. But most people get hospice in their own home. And that's kind of the beauty of it, really. When you've got a disease process that isn't going to get better, medicine has said, hey, we've done everything we can do for you. You're not looking at the high level of medical care of the hospital anymore. You're looking at what's going to make me happy right now, and that's being around my family, being being around my dog, being around my photos and my familiar smells and pictures and things. That's what people want a lot of the time. And that's really the message overall of hospice, is that we're there to provide comfort. Rather than curative care, we want to maximize the quality of your days, not the quantity of them. So hospice is often done at home. Now sometimes the person's needs exceed what we can do in the home, and we do have agreements with facilities that can provide 24-hour nursing care, but it's usually in short bursts. It might be 3 or 4 days that you go to a facility for, get well managed, and then we get a plan and we get you back home again. Unless you go live in like a private pay assisted living facility, that's the only time where it's like we're doing hospice in a place like that. Does anybody have questions about that one?
You need a doctor's prescription, like you used to do in the old days, to get into a hospice
You do.
situation?
Yeah, you do need a doctor has to oversee the plan of care, and they're the ones that certify that somebody has that terminal illness, right?
A terminal or the terminal?
A terminal, yeah, so think of a few terminal illness. Let's talk about COPD or heart failure or maybe even cancer, right? How many of you guys have known somebody that has one of those things? How many of you know somebody who's surviving or thriving with one of those things? All right, so we can have diseases that, kind of fit into that list of terminal illnesses. If I wrote a whiteboard now and listed all the terminal illnesses that we admit people to hospice for, you'd be like, man, I've got like 3 of those. I better get on hospice. Not yet. We have to wait until that disease has impacted you. Hey.
So to the lady that just asked the question, Jason's right, we do need a hospice order to admit, but you can speak to anybody about hospice at any time to get information. So you can have a conversation with me or Jason.
Yeah, you can, at some point you have to have a doctor's order, but to refer somebody to hospice, if you're sitting next to somebody, hey, this guy right here, I think he needs hospice, you can call Maggie's at any point and say, hey, my neighbor has every cancer and I think they might need hospice care. As long as your neighbor is okay with you making that call on their behalf and saying, hey, I'm going to have my friend Janelle here come and talk to you, we can start that process of consulting, talking to you about what hospice is and seeing if it's really what you want. Some people don't want hospice. Some people want the whole 9 yards till their very last day, and that's totally okay. But there's a lot of people that get tired of getting IVs and x-rays and lab tests and doctor appointments, especially when the outlook is that it's probably not going to make a difference in the end. A lot of people say, if I've got 6 months or I've got a year left, I'm going to spend it doing the things I love. They don't want to hurt. They don't want to be nauseous and deal with the consequences of that illness. So we take care of that stuff the best that we can. We're just not necessarily going and treating the illness and trying to get rid of it. We're trying to make it so you feel good, even though you have this stuff. That kind of brings us into when we were talking about the diagnosis a little bit. When those diagnoses get to the point where they've impacted you to the degree where maybe you're losing weight, or you're not eating as much, or you can't get up and walk anymore, or shower yourself, get dressed up. If it's impacting your day-to-day function, that's that threshold. Like I said, we know a lot of people with COPD or heart failure, and they're out bowling and living their life. Those guys aren't your hospice folks yet. But when it gets to the point where that person can't go bowling anymore because they're short of breath when they get up to put those shoes on, that's that threshold. When it's impacting them in a way that I need somebody to help me manage this so I can keep doing the things I love. So one of the things I think people talk about is, what does hospice do? And I'm sure you guys know we try to manage pain, right? What's the biggest drug you think everybody in hospice gets?
Morphine.
Morphine. Everybody loves morphine. That's what they gave the guy in Saving Private Ryan, right? Not everybody gets morphine. Morphine's a pain medicine, and a lot of people do get an emergency kit that has it in there. That's just so that our nurses, when they go out there, they have a toolkit of a little bit of meds that in the middle of the night, if somebody calls them at 3 a.m. and says, hey, I'm nauseous, we have an option. We don't have to wait for a Walgreens to But not everybody gets morphine. That's not appropriate for everybody. We have it there so we can treat pain, physical pain. What other types of pain do you guys think there are? What does pain mean to you?
Mental, yeah.
Okay, depression, mental pain. Maybe somebody hasn't talked to their son in 25 years and they're worried that they're going to miss that opportunity. Maybe that's causing the pain. Morphine doesn't fix that. What about mental pain? Maybe they walked away from their faith, 3 or 4 decades ago, and now they're starting to really have some concerns. Maybe they need somebody like Gary to come sit down and let them know that either they are okay or where we need to go to get them there spiritually. Maybe they need to talk to somebody. That's pain that morphine can't fix. Now, if you've got cancer pain and it's pushing on your spine and it's causing you physical pain, morphine might help with that. And we'll be there for that if it does. But pain is a much bigger issue. And that's a little bit of why we like to have a 6-month window, people if we can, because Gary can't do that job in a day. All right? He can go help out, but it takes meeting with somebody. It takes time to get that son to come back around. It takes time to help somebody plan their affairs so they feel comfortable that their loved ones are going to be well cared for and that their wishes are going to be followed through with. So Medicare gives us, they try to have us estimate as close to 6 months as we can. So when we're looking for those signs of decline, those people that now are losing weight or they're having some impairment in their ability to do daily things, a lot of people don't know if they're really there for hospice. Sometimes the doctor says, well, have you ever thought about hospice care? And I'm like, no, just bowling last week, I just told you I'm a little short of breath. Well, maybe that's a sign. One myth here is that hospice is this 11th hour kind of intervention. And it's really, we can do that, and we will. We hope that we get a few more hours with you than that, though. In order to really get the full benefits of hospice care, that means building a relationship with your chaplain, your social worker, your nurse actually getting to know you as a person and what things you like and don't like, what your preferences are. It's really a unique journey, and it takes us time to do that the right way.
So you don't have to be bedridden?
No, you're not bedridden. No, I would say most of our patients are not. Until the very, there's a point where where we're looking at the last couple weeks of life, and often, yes, people will get to that stage, but we hope that we're with you long before that. Because by the time you're bedridden, sometimes that means you're also maybe not talking a lot. You may not have that full mental clarity that you once did. We want to get with people while they can still let us know what their wishes are, what their needs are, where we can still get family there. Some people's families are all over the country. How many of you guys have family in other states? If you call them today, could they get out here? They might be able to. It would probably be very hard. But if they knew they had a few months here, they could plan a nice trip. They could make it work. They could plan some time to actually stay with you for the week and help you get affairs in order and spend some good quality time with you. So that's our hope, is that we don't get there at the 11th hour. That's tough because, again, a lot of people don't feel like they're ready for that. They're still in the fight, and that's okay. But it's never a bad idea to have a consultation and talk to somebody. One other myth here is that hospice makes you stop a lot of your medications and things like that because we aren't treating the disease anymore. That doesn't necessarily mean that we have to stop your meds, though. We may give you some morphine, right? But can you still take your lisinopril and your atorvastatin? You can. Not everybody wants to. Some people want to take less pills. But if we bring you on for heart failure, am I going to keep you on your beta blocker? Probably. Unless there's a better med out there. We're going to keep you on your Lasix. I might pick a different med than Lasix, but we're going to keep you on that water pill maybe, as long as you like taking it and it's doing good for you. This is really a program that's driven by you. Our whole lives we've spent going to the doctor, and the doctor tells us what we're going to do, right? Say, all right, I need to have you take this pill, your blood pressure's high, your heart rate's not good, I'm going to have you take this. How many of you like taking pills? How many of you have taken a pill that you really didn't like the side effects of? Yeah. We do it because it's what the doctor told us to do, and it probably is the best thing for giving us longevity. It doesn't necessarily mean it's the best thing for quality of life. Who likes getting up in the middle of the night to go to the bathroom 4 times because you took a water pill? Not everybody. So you're gonna get to work with a nurse, multiple times a week, not once every 3 months, right? And instead of 15 minutes at your primary care doctor's office, Natalie and Allison will be there for 45 minutes or an hour. They can talk to you about these conversations and the pills. He always had questions about, why does the doctor even have me on this? I just got a prescription for it the same way one day. Maybe she can make it make sense. Or maybe it doesn't make sense anymore. A lot of us, raise your hand if you don't want to, but how many people are on a blood thinner, like Eliquis or Xarelto, right? So doctor gave that to us because they don't want to have a blood clot, right? But as we age and we get, a little closer to the end of our lives, sometimes the risks of that outweigh the benefits. Sometimes we need to reduce the dose. Sometimes if you're having falls, you could be at high risk for having more bleeding rather than having a clot. So sometimes it makes sense to stop a med at some point. So we definitely don't make anybody stop things, but we can give them recommendations. We can have conversations with them about, are the meds working for you? Are they doing what you want? And if they're having bad side effects, we have direct access to a doctor constantly. If I dial Dr. Corey Kruger right now, he's probably going to answer the phone or send me a text message and say, I'll call you in 15 minutes. We have that close of a relationship with the provider. So when you need something and Natalie calls Kruger at 2 a.m., he picks up the phone. That's not access that a lot of people have, and that's one of the real beauties of hospice is that we take away the red tape, okay? If a patient needs a new prescription in the middle of the night, we have a doctor that can do that. We have a nurse that's gonna come to your house at 2 in the morning to see you and evaluate you, write orders, get them sent off to the pharmacy. We even have couriers who will drive that med up from Phoenix in the middle of the night, if that's what we have to do. So there's all that red tape is gone. You don't have to wait for insurance authorizations and things like that. We can just do it.
So do the people stop seeing their regular family physician?
They don't have to. Some people choose to, some people don't. And it kind of depends on the physician. Some doctors, there's a few in the Brady community, some in the Flagstaff community really like staying involved with hospice. Others don't because they know if they stay involved and Natalie calls at 2 a.m., you gotta answer. And they know that. Some of them stay in it for 2 weeks and they say, Corey Kruger's getting paid to do that. Why don't you let him do it? Just give me an update every week. They want to have somebody like Janelle does that. She'll go to your primary doc and say, hey, Bart's doing great and things are going awesome. Just wanted to keep you up to date. But some doctors do stay involved, and that's really between the patient and the physician. You totally can have your doctor there. There's a point where, and sometimes it's this point where you're appropriate for hospice, where it's hard for people to get out of the house. Maybe they're not driving anymore, or they need a lot of oxygen support, and it's tough lugging tanks around and carting all that over to the doctor. Our providers can come to you. Nurses and nurse practitioners can come out to your house. Dr. Kruger even makes house calls occasionally, not all the time, but if need be, he can. So it just depends on what y'all want and what your needs are. If you want to still go to your primary doc or have the hospice doc take over. It's a specialty. So you go to your primary doc and he sends you to the cardiologist, right? Doctor's still involved, but it's the cardiologist that's the one that's going to make some calls, whether we're doing surgery or whether you need a new heart med. Hospice is kind of the same way. When you're dealing with complex pain and advanced disease processes, they're specialty trained to deal with this. Where your primary care doctor might be, they might not be. So it kind of depends on their level of comfort as to whether they're going to stay involved and to what degree. So that answer the question well? We definitely always keep them in the loop, though, even if they're not directly involved. So another myth, who's ever heard people talk about hospice just giving people morphine and then they die? Ever thought about that? Or assisted suicide, people talk about euthanasia. That's good. Maybe that myth's dying out. You've heard that before. This comes from family members a lot when I hear this one. You get somebody on hospice, Janelle's had a great consult with them, and they say, hey, I really like this idea. They get on service, and their son from Kentucky calls and says, you put my mom on morphine? What does she need morphine for? The doctor says she just has congestive heart failure. What does she need morphine? They don't understand that we have that as an emergency kit. And they don't always understand that while we will medicate somebody to not have them in pain, we're not going to ever medicate them to the point where they're going to pass away. We support people that have a disease process that ultimately will result in death, but we are never the mechanism of death, if that makes good sense, put it that way. So even though somebody might be on morphine or they might have some comfort meds, it's never going to be something that would expedite death. There are some states that do that, and there's probably hospices in those states that work with people that have laws for that, but that's not something we do in Arizona. So if you ever hear that, you can help dispel the rumor. Did you have a question? No, that's not doing it up there. One final myth I have written here is that, what about the cost? Has anyone ever thought how much does hospice cost?
When I said I was coming to this meeting, my husband said, why? We can't afford hospice.
So hospice costs $0. If you qualify, if you have Medicare, right, and a lot of you probably do, there's generally no cost for hospice. Some people may have insurance plans with co-pays, but I don't know that I've ever seen one. And if they do, we don't collect it because I don't even have somebody to do that. So if you come on with Maggie's, there's not going to be a cost. The regular Medicare benefit covers hospice 100%. As long as you qualify. Okay? And that means you meet the criteria that Medicare has given us. Each disease process has its own criteria. The doctors know that, and they write a letter that's called a certificate of terminal illness. And if they vouch for you and say, yes, this person has a terminal illness, they qualify, and there's no cost. The only trade-off to it is, let's say that you come on hospice for congestive heart failure. Okay, anything related to congestive heart failure or heart at all, we take care of that. If you go to the cardiologist and he tries to send his bill to Medicare, it won't go to Medicare, it will come to me. And we may pay that, or we may say, hey, before you go to the cardiologist, why don't we see if Dr. Kruger can help out? There are times when people want to go to that oncology appointment one more time, or a cardiology appointment, and we've been able to figure that out for them. We just have to work with the provider. So it's kind of a trade-off. You're trading that active treatment for the comfort care at home. And it's a pretty good trade. You get a lot of resources that come to your home in exchange for going and not seeking that active treatment anymore. So most of the time people wait until the doctor has said, hey, there's no more active treatment I can really do for you. That's when it becomes a really good trade, because you're really trading for nothing. You're getting hospice there. But it's a replacement benefit, really, for that one diagnosis. Now, if you're on for heart failure, what happens if you break your ankle? Can you go to the hospital still? Definitely can. And you can go see the orthopedist, you can fix your ankle, do all that stuff. Sometimes we will step out of the picture momentarily just to simplify the billing for the hospital. If you have to go in and you're going to have surgery and you're going to go to the nursing home for 2 weeks and get some rehab, we will probably step away and say, all right, they've got you. Give us a call when you get back home. Because we don't go into those facilities and do our care, because they've got nurses there doing that. It can get a little cumbersome when you have multiple docs and multiple people getting involved. So if you go to the hospital when you're on hospice, sometimes we will say, all right, we're going to discharge hospice until this is all figured out, and then if you want to come back on when you get home, then we just come back out and set you back up.
So then does the patient need to re-qualify, go through that process again?
It's the same process, yeah. But when, let's say Dr. Kruger's had you on hospice, he knows you already, he's familiar, and it's a pretty smooth and easy process to get somebody back on hospice. And oftentimes, if you're going in for some kind of big active treatment, it makes it even easier because there's another medical issue on top of what you already had. So it's not hard to get back on if we do go on. Yes, ma'am.
And music.
Do we have music? We can, we up in Flagstaff, we have a couple chaplains who are great musicians and they use that a lot. I don't know as much if the Verdi team has had that yet, but.
Not currently, but we do have had some volunteers, that didn't make sense. We've had some volunteers in the past who play the guitar. We're always looking for volunteers too.
If you're a musician and want to come play for us.
Yeah, but we have lots of resources throughout Flagstaff and Prescott that we can pull through, so.
And I think that if we really had somebody with that need, I'd bring our chaplain from Flagstaff down to do that.
Hospice. She died unfortunately. But hospice had music every week. And people loved
It is super nice, yeah.
Yeah. Old songs.
Was she living in a facility at that time?
Yes, she was.
Okay. Yeah, that makes, sometimes they'll have a piano. When we do it at home, a lot of times it would be like guitars, or people will play flutes and things. So whatever somebody's needs are, we're going to try to see if we can find a way to make it work. What did you have, Gary?
Well, I learned from my chaplain supervisor and trainer to use your iPhone and a little portable speaker, and you can have all kinds of music according to their taste. And so I have a 95-year-old patient who loves to hear music from the Mass, and so I take that with me every time I see her.
I'll tell you a fun music story. I had one of my earliest hospice patients I got to work with. I've been a hospice nurse a few years, and this lady had something called aphasia. She couldn't speak anymore. She could understand me, but she could not use words. The interesting part, though, is that she could sing. So she couldn't tell you, I want some toast, but she could sit there and sing Tina Turner songs. And that's what she wanted me to play for her. I had to learn to play Tina Turner on my guitar and sing to her. And that's what we did. And so she would sit there and sing, and her husband was just like, blown away because he's hearing her voice. And he didn't ever get to hear it except then. And so it's interesting the things you see, but yeah, music is awesome, and we always want to add more, as much of that as we can to the hospice care, or any other thing. We're going to try to tailor that care plan to the patient. And if somebody likes to talk about old cars, and we happen to have a nurse who's an old car person, we're going to bring that person out. I got to go visit a patient not too long ago with the Verdi team, who was a big guitar guy, and I like guitars, so they asked me to come do a joint visit with her, and we talked about guitars and amps and stuff like that. So we definitely try to tailor our care team to the patient and their interests and likes and things like that.
Could you compare and contrast hospice care to palliative care?
That's a good one. So they're really close. So let's say we've been going on CHF. So we got CHF here, and we're maybe not quite to that hospice point, or maybe you're not quite to the point where you want to give up some of the treatments you've been on. Maybe you're going and getting a valve replacement or something like that. Palliative care, you can still get a lot of active treatment, but the focus of that treatment is meant to be something that's going to cure pain. It's not necessarily going to cure the disease. They might do radiation for somebody. Maybe cancer's a better one than CHF here. So you've got some cancer, maybe it's in your throat, and it's causing you a hard time swallowing. On palliative, you would still go and maybe get radiation. You might still be on chemo. The doctor might have told you, hey, this probably isn't going to fix this, but it's going to make it better for a while. And as long as it's improving things enough that it's worth the side effects, which sometimes radiation can cause some pain, chemo can cause some nausea, some other issues. But overall, it's a good trade-off for you. Palliative might be the way to go. Now, once you've exhausted that, maybe the doc's like, hey, there's no more radiation we can do. The chemo's not doing anything anymore. When you come on hospice, we wouldn't probably be doing a lot of those more aggressive things. We'd probably get you on some steroids. We'd give you the the medications to manage the nausea. We do everything we could to keep the tumor size down, or modify how we give meds, switching things to liquid medications instead of pills, helping process food differently so you can get it down easier. So with hospice, it's purely comfort care. With palliative, that's kind of the bridge between full-on aggressive treatment and comfort. Palliative is that place in the middle. Most of the time, palliative is done in office, but there are home-based palliative programs where a nurse practitioner can come out to see you. Sometimes palliative is going to be the support team that's refilling your pain medications while you're still going to oncology to manage that care. Pain management is its own specialty. Many of you guys ever been to the pain management doctor before? No? So if you have real complex pain needs, your doctor will refer you to a doctor that does nothing but pain management. That's their specialty. They go to school especially for it. That doctor isn't the oncologist. He goes to school for cancer training. He knows how to write all the chemo orders. So if you're going to oncology and you have some pretty tough pain needs, likely they're going to say, hey, you know what? Why don't you go see your Dr. Downing over at Palliative? He can help you out with this. Palliative docs are going to be comfortable writing some pain meds that maybe your primary care doctor doesn't want to write. Maybe you need something like methadone or fentanyl. Your corner urgent care doctor doesn't want to write those prescriptions usually, but a palliative guy probably would. Hospice doctors are also trained in that same level of pain management. So that's something that hospice physicians are usually okay with managing for you. So that crossing point, though, is basically you need the symptom management, but you're not ready to give up the active treatment. It's palliative. You need the symptom management, and you're no longer seeking aggressive care. Hospice.
Is the palliative care covered by Medicare, just like hospice?
Yeah, palliative care is this interesting gray area. It's covered much like primary care is. So when they do palliative care, if they do a palliative home visit with you, they're going to bill it much the same way that your doctor does when you go see them in person. The difference there, though, you're not getting that 24-hour nurse coming to your house. Palliative's not going to have the chaplain aspect or as much social worker. They probably have a social worker there at the palliative office that helps you with some life planning and some, do not resuscitate orders and things like that. Hospice is just going to be a lot more of that and completely home-based usually. So with palliative, you might see a provider maybe once a month. Maybe the nurse practitioner comes out and visits with you for a little bit. With hospice, you're going to be seeing people 2 to 3 times a week. So it's just kind of a higher level. Yes, ma'am?
How do you spell palliative?
That is a great question. I'm going to try. Let's see. Palliative. Palliative. Correct. I'm glad she asked me what I actually knew.
Is palliative care maybe a step towards hospice?
Yeah,
in
definitely.
many cases?
Oftentimes. So the scenario probably goes like this. Right? You're at your doctor and you get that tough conversation. You've got, cancer. Okay. He says, all right, we're going to refer you to oncology. Okay, we're going to go for that. You go to the oncologist and he says, man, this is bad. I'm not going to be able to fix this. But we can definitely keep you comfortable. We can try some chemo. We can try some of these things. But they might refer you to palliative at that point because maybe you have some pretty bad symptoms. You've got substantial pain, some nausea. Your quality of life is not in a great place. Palliative's job is to get your quality of life better. Oncology's job is to try to attack this cancer and maybe get rid of it or do the best they can with it. So it's that in-between place where now once you've done all the chemo, you've done those things, and maybe you've said, you know what, I've been doing this for a year, I'm tired of this, I'm good with the Lord, I'm good with my family, and I'm ready, I just want to be comfortable in my house. And it's hospice. Okay?
But with palliative care, you can maybe get better and get off of it completely, and now you're skipping around going bowling?
Absolutely. And you can even do that on hospice. Okay.
Oh, yeah.
We get a lot of referrals. Okay. Somebody comes in, is good hypothetical here. I don't go to doctors. I don't believe in doctors, but I went to the ER the other night and I've got really bad COPD. All right. And now they say I need oxygen and they say I need hospice and I've been losing weight. Well, yes, if that guy gets left alone and nobody does anything, very possible he may not live another 6 months. But part of the reason they're in that situation is he's not well managed, all right? Nobody gave him a steroid, nobody gave him oxygen or an inhaler. So if we get in there, we throw nurses in 3 times a week and a doctor that's noting on him and reviewing his case every week, he's probably gonna get better. And that happens a lot, actually. We get somebody on steroid, they start breathing better, we get them on some meds to manage that COPD, we get them some boost, and we get them active again. Now they're feeling good enough to get out, they go back to bowling, and life is good for them. We can take you off hospice. And when that happens, we call that a live discharge or for extended prognosis. And we do that fairly frequently, actually. There's no crystal ball. Your doctor may think, man, doesn't look good today, I'm giving her a hospice referral. And maybe you're better though in 3 months and you're looking pretty good. Take you off, and if things go downhill again down the road, we'll definitely come back in. But that's part of our duty to Medicare. If somebody gets better, we actually have to take you off. We plan that when it happens. Say Allison comes out, she's been seeing you for 3 months, and she's like, man, you're actually gaining weight, and maybe you lost 10 pounds before you came on hospice. That's what initiated the referral, but now she's been getting your meds dialed in, and your edema is down, and you're breathing better, and you're up to moving around, and your chaplain's been getting you spiritually fed, and you go back to church, and now you're good. And she's going to say, hey, we're going to discharge. She'll call your primary care doctor, let them know, or if you don't have one, like our guy in the story, we'll get you one. That's part of that process, is we're never going to discharge somebody and leave them high and dry. We want to make sure that you've got a good care plan, and it could be discharging to palliative. We do that a lot. That's a back and forth dynamic that's actually pretty fluid. So if maybe you're not meeting hospice criteria, you're doing well, but you still need some pain management, maybe we're going to get it back to primary or back to palliative.
Please tell me the difference between Alzheimer's and dementia.
Woohoo! I love this one. I'm going to drink. This is a long one. All right. Alzheimer's is dementia. Put that one down.
Alzheimer's what?
Alzheimer's is dementia.
Oh, yeah.
Alzheimer's is a subcategory of dementia. Several different varieties of dementia. Alzheimer's is one of them. And it's a unique one because, we'll call these neurodegenerative disorders. Of the dementia types that we bring people on to hospice for, there are 3 main ones. Okay. Lewy body dementia. Anybody know anybody that's been diagnosed with that? You heard about Lewy bodies? Parkinson's dementia. A lot of people don't know that is dementia, but it is. And Alzheimer's dementia. Okay. Alzheimer's, Parkinson's, and Lewy body. All of those fit under the umbrella of being dementia. There's a couple other disease processes that are referred to as dementia, but they're unique, like vascular dementia. And there's a few other ones that kind of are in their own little categories. The big 3 that I just mentioned have to do with protein folding or misfolding in the brain. Okay. Parkinson's and Lewy body are actually the same disease, and it's due to a protein called alpha-synuclein. That's a big fancy word. And when it happens in the frontal part of the brain, we see symptoms of Lewy body dementia. We see hallucinations. We see people who having sleep disturbances. We see people who, when they stand up, their blood pressure doesn't raise, they drop and they fall. With Parkinson's, what do you guys know about Parkinson's? What do you see with that disease? The shakes, right? That's
Oh, yeah.
where that protein is misfolding. It's more the part of the brain that's to do with motor function, right? So these guys, they move a little slower. They might have the shakes. They might shuffle their gait a little bit when they walk. But oftentimes, at least initially, they're clear as a bell upstairs. They're not hallucinating. They're not having any problem. As these diseases progress, they end up coming together, forming something we refer to as mixed dementia. You end up, if you get the Lewy body problems first, we usually just call it Lewy body. If you get the Parkinson's problems first, we call it Parkinson's. But in the end, they kind of end up running together a little bit. Now, Alzheimer's is unique in that it has beta amyloid and tau proteins in addition that are misfolding. And it progresses in a very specific sequence. We call that the FAST sequence. You guys ever heard of a FAST score before? More of a nursing thing, but a lot of people don't know this, though, that Alzheimer's happens in a very specific order. And that's how we know when somebody is getting ready to come on hospice. It's a 1 through 7 scale, and each step has a specific set of symptoms that happen at it. So if Natalie calls Dr. Kruger and says, hey, I've got a patient here, and Janelle and I are talking to him, they've got Alzheimer's, Dr. Kruger is going to say, what's their FAST score, Natalie? She says, they're FAST 7A. That means that they've lost control of their bowels, they've lost control of their bladder. That's moving us through stage 6. And their ability to speak is limited to about 6 intelligible words or less. Okay, so if they can have a nice conversation with us, hear about these things, they're not Alzheimer's 7A yet. But if the only conversation they have doesn't actually make sense, they say, Captain Crunch, peanut butter aliens, that doesn't count. Those words don't make any sense. So that person might, even if they have a string of 14 of those words, they can name every cereal box and old president, but it's not coherent. They still may be at that point where they're not having 6 intelligible words. Most of the time what we see, it's not that. I've never had anybody name cereal off to me, but usually it's very limited, 1-word responses, yes, no, or the response doesn't make any sense. Are you in pain? Yellow. Okay, it's not registering there anymore. That's the threshold where Alzheimer's becomes a hospice-appropriate diagnosis. Oftentimes, when somebody's at that level, their oral intake has also started to decrease. They're not hungry anymore. Their bodies are starting to everything is slowing down. The brain, but also everything's connected to that. So usually, they've started to lose weight. They're starting to get out of the bed less. Maybe they're needing more help into the bathroom, in the shower. Those are the earlier stages of Alzheimer's. You'll see people not able to choose the right clothing, not able to bathe themselves or feed themselves anymore. They can eat if you feed them, but they can't. That process of picking up the fork and putting it in your mouth is no longer functional. And that this is a progressive thing, and it starts and those proteins continue to misfold, and we start to see those specific functions are what decreases in that order. So Alzheimer's is unique in that way. Other forms of dementia are a little more random. You may or may not see some of those things, but they don't happen in a sequential order like that. So each form of dementia, we look for specific criteria. We're going to bring you on for Lewy body. I'm going to ask, is the person hallucinating? They have vivid visual hallucinations. When I sit them up, Natalie will check their blood pressure laying down. She'll sit them up, and if the blood pressure drops, their heart rate spikes up, that's a positive sign for me that says, yeah, they have neurodysregulation. They also act out their dreams. So if any of you have a spouse and you're sleeping beside them, most of us don't know this, but you're paralyzed during a large portion of your sleep. You don't move. You may be running from a bear in your dream, but you're laying perfectly still. Not the Lewy body patient. When they're running from the bear in their dream, they're literally doing this in the bed. And so if you see that, that's a sign, hey, maybe there's some of this starting to happen. With Parkinson's, the thing that we see the most, obviously we can see the shaking, we can see the gait, but they'll also, the point where we bring them on hospice, they start to have some dysfunction in their ability to swallow effectively, and they'll start to aspirate fluids. They end up getting some pneumonias, and usually they go to the hospital once or twice. The doctor gives them antibiotics, and it gets better. Eventually, they get sick of going to the hospital, and like, hey, what's going on here? And they have a swallow study, and it shows, hey, you're actually having some difficult time controlling that airway protection anymore. And that's usually a sign to us of, hey, that's when it's time to bring somebody on for Parkinson's disease. They usually are also losing that ability to walk safely. They start falling and tripping because they can't lift that foot the same way. Did that answer your question on the Alzheimer's?
Yes.
All right.
I had an experience with my cousin. I went to help her. Her husband had Parkinson's. He was an invalid in bed now. And she was thinking about hospice but didn't know anything about it, hadn't done any research. And so we started looking and calling. And she really didn't have any idea about what questions to ask. And so it became just, okay, what are you doing now that you need help with? And how can hospice help you? And what do you see in the future? And she knew he was near death. And so those were the questions she asked them and chose someone. And one of them was, how many times can you come? Well, this particular one only came twice while I was there, and I was there 3 weeks. And then they ended up coming at the very end when her son and daughter came, because they knew it was the end. And they came during that time period. But it was very unsatisfactory as far as I was concerned. And at the same time, she was pretty much exhausted. And I often wonder, which leads me to a second part, how do you qualify to be a hospice company? How do you find out which ones are the best ones? And she ended up just kind of looking at the comments from people who used different ones. It was okay, but in the end, it didn't really work too well for her.
So this is a part I love and hate about hospice. It's something I love about Maggie's. It's something I hate about the hospice business world in general. So Medicare has some very minimal requirements for hospice. The nurse has to go see the patient every 2 weeks. And a lot of these companies are doing this specifically to make money because you get paid on a daily basis. It's a per diem rate. So with Maggie's, the minimum our nurses go unless you tell them not to. They start it twice a week for just nursing. Chaplains and the social worker will start 1 to 2 times a month, depending on what the patient wants. But they can come as often as they need to. If Gary says, hey, I can see this lady every week, going out there, then that's fine with us. If the nurse says, it's time for me to go to daily visits, and we do that closer to end of life because there's more things to manage. But really, it's a very personalized thing. If we have a patient who's maybe not, far advanced, but we've got a spouse that's really struggling with this, we might still go every day. We might go 4 or 5 times a week. It's really personalized there. We don't give them any restrictions on how often they can go. We give them some guidelines and some minimal. So we have a scoring system. This is a hospice thing, just like the FAST score, we call it PPS score, Palliative Performance Scale. And when somebody comes on hospice and they're walkie-talkie, they're doing pretty well, we call them PPS of 50, maybe 40. As they decline a little bit, they might become that PPS of 30, and they're starting to be more bedbound. PPS of 20, we're getting very close here. PPS of 10, they're actively passing. So once our team reaches a PPS of 20, we automatically go on daily visits. There's going to be a nurse every single day, unless you tell them not to come. And you can do that, say, hey, my son's coming today, I don't want you guys around, stay away, come back Monday. You can do that. But we're gonna tell the nurses that we want them to see you every day. The social worker's gonna start coming more frequently. So yeah, a lot of teams unfortunately don't do it what I would call the right way. Maggie's has never given us restrictions in that way, and I love that. We're allowed to do what we need to do for the patient in terms of visits, medications, whatever they need. But there are are some bad players out there. I wish that wasn't the case, but all we can do is try to do it our way, and hopefully we grow and our reputation spreads and people choose us. And the first part of your question, though, how do you figure it out? That's part of what Janelle's job is. She spends her day every day talking to people about hospice, coming to events like this, talking about hospice. And when people want to know about it, sometimes she meets with them and hospice isn't right for them, or they're not ready yet. But she can give them a call in a few months. She can follow up with them, or they have her number, and so they'll call her and say, hey, I think I'm ready. Sometimes that might be months at a time. She met with them 3-4 months ago. They said, no, I want to keep going to the oncologist. And then eventually they say, hey, Janelle, I think I'm ready for hospice. The Google thing can be very enlightening. One thing I'll tell you about it, it's very polarized. The people that are going to leave you a Google review are the people that absolutely love you or that absolutely hate you. So you get a little bit of the polar end of that. The one I would say is maybe a higher quality indicator is Medicare actually has a Hospice Compare website, and they grade us on quality metrics. So timeliness to care, how well was pain managed, how well did the nurse educate you on the plan of care, things like that. They have several metrics that hospice families get surveyed on. So if your family member's been on hospice and they pass, Medicare will probably send you a survey. And they actually tally the scores, and there's a website where you can click compare Maggie's to Acme Hospice, and it'll show you what our scores are, what theirs are. It shows you our census size. So big hospice versus little hospice. You get, when you're on that little hospice that only has 10 patients, you're definitely going to be a focal point of care, right? That hospice also, though, might not have all of the resources that a bigger program has, like full-time night nurses, full-time weekend people, administrators and doctors on at night. They're building it up, but they don't have that stuff yet. I kind of like the medium program size. You get too big of a program, then you kind of get lost in the shuffle there, right? Maggie's is kind of a medium-sized program. We're one of the bigger ones in this area, but we started as a very small program. We started with one nurse, and it's kind of built on that reputation of quality. And so we have grown, and our number one effort in the growth is to keep that small hospice quality while still spreading the good word there a little bit.
Are some hospice programs provided by non-profit organizations?
Yep. You can be for-profit or non-profit. So that it's just a difference a little bit in the company's structure. I would say that we are a for-profit company, but we run more like a nonprofit than even the big nonprofits. I worked forever for Banner, and they were a nonprofit. Our CEO made $22 million a year, so somebody was profiting. So that it's good to look into what that really means. But yes, there are some that are nonprofit. We have in the past and are going to have again soon a nonprofit branch where we can use for like charity cases and stuff. Right now, if I want to bring somebody on for charity, they just let me. So we have a lot of charity cases that we bring on, and that's just something we do.
Let's assume that you're looking for a hospice company and you're examining 3 different ones. Can you expect them to provide you with documentation as to what they're going to do? Like visit once every 2 weeks or visit twice every week, or what?
I would say it's a reasonable question. I bet you they're going to all say, well, it depends on what your needs are. That's probably how they're all going to answer that. It's going to be driven by your symptoms and your own desires too. If Natalie goes out and says, well, we're going to have the nurse see you twice a week, and you say, you know what, I really love it Monday, Wednesday, and Fridays, and okay, fine, let's do Monday, Wednesday, Friday. It's not a big deal. We can do it more if you need more, because back to our pain discussion, is loneliness pain? Maybe you just want somebody there with you. You don't want to be alone when you feel like you're dying. So if that means we send social workers or CNAs or chaplains, somebody can get out there every day. Somebody can get out there twice a day if we have to.
Just along the lines of what was said, I mean, hospice is a very profitable endeavor through Medicare. Medicare saves a lot of money by having people choose hospice because they are now no longer, I mean, that's kind of the setup of it. I'm not being cynical about hospice. I'm a huge supporter of hospice. But just to the questions around how personalized it can be, I think we should all feel very empowered if we get to the place of hospice to totally ask for what we need, because while we're not paying anything, it is being paid for by our Medicare. So it's a mind shift, I guess, to really utilize the benefit that that's there. And that's not a criticism of hospice.
No, it's a good thing to ask, and I think they should be upfront with you. I would ask, hey, can you send a CNA every day? If they can't, they should tell you that. Or she might have to say, let me call my supervisor and check. And if I've got the staffing for it, absolutely. If I don't, then I need to hire somebody. I can't say every hospice is going to take that approach, but I think you should definitely feel empowered to ask them, what will you do for me? I think it's probably important to cover one topic here, and that's skilled versus non-skilled care and custodial care versus what hospice does. So in terms of, a lot of times we get family members, they come into town, mom or dad's not doing well, and they're here to help set up resources. So they just pick up the phone, they start making some calls. My mom needs 24-hour care. I need to get, my understanding is that hospice provides 24-hour care. Kind of true. We can come out 24 hours a day. We have nurses on call, day and night, 365. But they don't sit there with mom or dad 24 hours. There's certain circumstances where we can, like if something crazy was going on, somebody's having a seizure, yeah, Allison's not gonna leave until she gets that fixed, or, until the end, we're gonna stay there until we get it fixed. But in terms of like having a live-in 24/7 caregiver, that kind of falls into the category of non-skilled care. They're there to clean the house, feed the cat, do the washing. Our aides can do some of that stuff. If they're there to give you a shower and you say, hey, can you put on, some oatmeal for me? Absolutely, they can do that. But the CNA is probably going to be there for an hour, hour and a half maybe, and she's going to come 2 or 3 times a week usually, unless you need more. She could come 5 days a week. On the weekends, it's probably going to be a nurse that comes rather than the aide. But I would definitely ask for that commitment, and Janelle, I should defer this to you, but when we hear about non-skilled needs, she will usually hook them up with a company that does that. Say, hey, we've got, who's your company here?
So we utilize a couple of different agencies. If I feel the need at time of consult in admission, I'll give them those resources right away and have them get in touch, or have those people get in touch. If it's after admission, the social worker will help tap into those resources. But we do have, I call it a plethora of caregivers that will be needed, because the spouse or the loved one cannot do it like they think they can overnight. So.
And that often spurs the conversation I'll get right here between, do you do it at home or do you do it in an assisted living? Those care companies aren't cheap. So families a lot of times will pick we want those guys to come at night because we can have the hospice people come in the daytime, and we might stagger it. The nurse might come in the morning, maybe the CNA comes in the afternoon, Gary comes sometime in the day. So we've got some people there throughout the day. Maybe mom or dad does just fine during the day, but when it's nighttime, when they're having those falls, especially for dementia, because it's nighttime when the hallucinations are the worst, when they're having REM sleep disturbance, some people call it sundowning. You'll be totally fine in the day. You might wake up tonight thinking you're in Korea looking for your Jeep. And that's when you need that caregiver. They're like, nope, let's go on back to bed. Your tent's right here, let's get you tucked in. And they get you through the night. So it's a hybrid of the two teams oftentimes. So yeah, we can definitely provide a lot of service, but it's supplemental. So generally speaking, hospice is optimal when there's a caregiver in the home. Somebody to at least pick up the phone and say, hey, I need some help over here. Doesn't mean we can't do it if somebody doesn't have a caregiver, but it's not the safest scenario. Unfortunately, sometimes we got folks that don't have the resources to go to a facility. At that point, social work is going to get involved and help get them on all tax or some other benefit if we can. other than that, we do the best we can with what we got, and we get as much services in there as we can swing.
Could you talk more about the social worker that's part of hospice and what their role is?
I should do social worker, that would be good. We have one here. So I'll do the best I can. I can't aim to tell you everything that they do, because it would take all day. They're amazing people. Social work, the number one thing they're going to go in and look at is the dynamic, what's their home, their housing, what financial resources are there to use, where are the deficits, can they afford their meds, do they not have power, do they have water, are they safe, is this care environment working, or do I have a daughter who's absolutely beside herself trying to care for a dad who's maybe violent. Maybe the dementia's gotten so bad that he's hitting her when she's trying to change him and she can't get him out of that grief, and he's been in it for 3 days now. And she's just emotionally spent. Social work, nursing, the whole team is going to be assessing that, but oftentimes it's the social worker that's going to go in. We had a scenario this week actually where social work really went in and saved the day. We had 2 people with advanced medical conditions and a very young caregiver who had been designated, and basically all the responsibility and power of attorney, everything put on that person. And social work went in to make sure, one, is that person okay? Like, are they dealing with this? Do they even want that? So they're an advocate for the patient. If there's something inappropriate going on, maybe our long lost cousin Kenny is stealing money from grandma's account. Well, social workers can go tackle that and make sure that that gets stopped. They might be getting letters for people written from the doctor because they need to get power of attorney enacted. They might be doing do not resuscitate orders for patients, or maybe somebody doesn't have a will and they want to do one. They can help them with all that life planning. I think there's also a component of it with some patients of being a bit of a counselor. We do have a little bit of a line there. We try to get people 2 resources. So if you really needed a counselor, like you've got some deep, dark depression stuff, I'm not going to try to unpack that as a hospice social worker, but I'm definitely going to advocate for finding you the person that can do that and help you out and follow you and make sure that you're getting it taken care of. We do have a few of our social workers and chaplains who are actually licensed counselors, and sometimes if somebody can't get out to a counselor, we might get somebody like that involved to help support them. So it's a really wide variety, but they're basically your catch-all for everything that's not medical. And the nurses and the social workers, they kind of cross over a little bit. So there's a lot of teamwork there, because it's usually these problems are complex enough that one person can't tackle it alone. And we like having somebody else's eyes and emotions on the situation, because we get close to you when we're working with you every day, and sometimes we get lost. We can't see, and some of that social worker comes in and says, no, something needs to change here, guys, and they can help us see that forest in the trees a little bit. Yes, ma'am.
Can you speak to, how do I want to say this? So many people, when you say the word hospice, they think death is imminent. You know, like it's 3 weeks from now, or, hospice means you're going to go to hospice and you're going to be there a month. I've known people that have been in hospice for over a year or longer. I mean, is there a time, I guess, is there a time limit? How does that fall into play?
Kind of yes and no. I'll give you the nitty gritty on it. Everybody gets 180 days on Medicare hospice service for their lifetime. Okay? So what happens if you get to day 181? Medicare has a cool system for this. They call it the CAP. That's like a little internal hospice phrase, but basically, as a hospice company, they look at everybody on your service, on average, how long has everybody been on? So for Maggie's thing, last time I looked at our average was like 63 days or something like that, a couple months, which we would love to get a little more time with people, but it's right in the middle of the road. Now, if at the end of the year you're a hospice and your average comes out to 190 days, you're in trouble. Medicare comes and says, please let us see your charts, and you're probably getting closed down. They make you give any funds that you've gotten immediately back. I think they give you 30 days to return them. So hospices have to watch that. Now, let's say I get a referral from Verde Valley Medical Center today, and that person is nigh on death's door, and they pass 3 days from now. When the doctor certified them for hospice, they got certified for 90 days, one chunk of 90 days. So I've got 87 days in the cloud. Now, if I got that COPD patient who happens to live for 8 months instead of 6 months, I can take those days and they're applied to him. Because that, it's this automated thing, really, it's that average. As long as we keep that average under 6 months, generally speaking, you're good. There are a few other red flags with hospice. Say somebody's been on, we do it in something we call cert periods. So the doctor certifies you for 90 days, 90 days. After that initial 180, it goes to 60 days. Every 60 days, the doctor has to re-see you, or the nurse practitioner, and write a letter that says, yep, she still qualifies. Here's why. They present the evidence and say, Medicare can say, no, we don't agree with you. You're not going to get in trouble for that, but you're not going to get paid either. Just sometimes that's a risk we take. We tend to, we're going to favor on the side of the patient, and if we don't get paid, we don't get paid. It's only happened one cert period ever for us. But yeah, there's some soft limits. Now, if you're on for, say, 13 cert periods, there's a point where the Medicare system is going to flag that. And once the patient passes, they send me a letter and they say, hey, please send us your whole chart. We want to audit it. And as long as the facts line up, if the doctor's CTIs and Natalie and Allison's notes meet the mark, then that might make sense. But that would be an outlier. Like, that's really what's probably going to happen there is they say, well, it looks like she qualified the last 6 cert periods, but those first 6 are a little soft, guys. We're going to have to take those back. So that's kind of how they manage that, is they know nobody has that crystal ball, and so they built actually a pretty good system for allowing this intolerance there.
So would that be an important question to ask if you're evaluating hospice companies as to what is your average?
I don't know that it's a top 10 question for a family, but it's something that the hospice is going to look at in a few instances. If you've been on hospice for like 6 months and you have the flighty urge to move to New York City, okay? You've been on Maggie's here and you're like, no, I always wanted to see you in New York, I'm moving. And you call that hospice in Brooklyn and they're like, you've been on how long? 6 months? Well, if they have a lot of cap space, they might take you and say, yeah, come on service with us. But if they're that little hospice that only has 10 patients, your case could throw them into trouble. And they might say, guys, sorry, either they're going to call me and say, hey, can you guys cover this? Or we have to find a hospice that has some cap space. So since our average is 63 days, usually I can take those cases. Some of the smaller hospices might have to pick and choose that a little bit. So it's the hospice company that's probably going to ask that question more than the family. If you're in a first or second cert, they're not going to worry about it because they're not in that cap range yet. If you've been on for a while, then it might be important to talk about.
If you don't have anybody, any relatives or anybody to help you, and you need help at night, what do you do?
That's a tough one sometimes. So we talked about the young lady that she may have stepped out. Sometimes if you have resources to hire, right, that's the first thing you could do. If that resource isn't there, okay, that's when the social worker is going to come in. There's a program in Arizona called Arizona Long-Term Care, or ALTCS. ALTCS is kind of the acronym, Arizona Long-Term Care Services. So this is a program that anybody can apply for. When you apply for it, they're going to ask you, first question, how much money do you make? And they're going to ask you to sign a form that says, can we look in your bank account and make sure you don't have millions stashed in ATMs around the world? If you do, you're not going to qualify because they want you to pay for the care then. But if you don't, what's the number? You guys know that off the top of your heads, about $2,100 a month or something like that this year. Right around that for a single person. I think if you make less than that, I want to.
I'm not an all-text guru, but there's something about properties and how
They look at
everything. They look at everything.
So Altex income limit 2026 for an individual is 2982. It went up, and for a couple, it's 5964. So that's the first question they ask. Do you make under this money? Spend money. And the next question they ask is, say, how many assets do you have? Do you have like 6 Ferraris in a garage out back? Well, they're going to want you to do something called spend down. I mean, you're going to have to sell at least 5 of those Ferraris. You can keep one. You can always keep one car. And if you live in your home, especially if you have a surviving spouse, that's off the table. You can live in the house. And they'll say, okay, you qualify financially. The next question is, do you qualify medically? And they're going to ask you a series of questions, like, can you take a shower on your own? Can you get dressed on your own? Can you make a meal? Can you take out the garbage? Can you operate a telephone? Things like that. If you guys ever go through this interview, in your head, but the tagline I want you to put on the end of every one of those questions is safely. How many of you have ever had a fall in the shower or getting dressed? I don't know if anybody has, but it happens. It's probably the most common place it happens because you're stepping over onto a slippery surface, you're trying to negotiate your underpants and your shorts and everything up. People fall down. If you're having falls and you're getting hurt, then you can't do it alone. Okay? So if you get in that interview, don't try to, really show your best foot forward there. You want to give them the worst case scenario, not the best case scenario. So they're going to score you on a system, a point system. And if you meet the score, then you qualify for all things. So if you've gotten that point where you just need help at night, that's kind of depends here. Can you be left safely alone? Not if you're wandering out in the street at night. So you have to, it's often good to have an advocate there at that meeting. Hospice social workers often attend those meetings. If you have a social worker at your doctor's office, it's good to have that person there to advocate for you as well.
I went through these kinds of questions because when my parents, this is like 10 to 20 years ago, there was no hospice where I lived. Maybe there was one, but it was nursing care. And those are the kinds of questions we have to answer. We will have that happen, and also to go into Medicaid. Those are really very strict questions that you have to be. I started to go to a lawyer, and he says, I don't want to waste your time and cost you money. You have to do your work. And so that's where I was, in the work with social workers and anybody that the place that I want to put them in, trying to find the best place. Go through them.
It's, I think another myth, it's not just a hospice myth, but it's in general. I was talking about my mom on the hospice a while back. And my sister says, well, at least Medicare will pay for her to go to the nursing home if she needs to. They don't pay for anything. Only if you have like a broken knee, right? That's for rehab. But to live there long term, that's a Medicaid thing or a private pay thing. But Altex is actually a pretty awesome program. Like honestly, of all the state programs I've seen, it's one of the best ones. If you qualify for it, you qualify for it in levels. So they might qualify you for 4 hours a day, 6 hours a day. If it gets to that 8 hour a day point, it starts to cross the threshold of it's cheaper to take you to home than to pay a private caregiver to be with you 8 hours a day. So they will often, you'll have an Altex caseworker, and they might say, hey, I think it's time we look over here at Green Acres, and maybe that's a better bet for you if you need somebody always, because they have caregivers 24 hours a day there. It's not a choice you have to make. You can still choose to stay in your home. If you do, let's say you're living alone, you're a sole entity, and you choose to go to Green Acres, then that's the only time where Altex is going to say, hey, you got to sell the house. Okay? And that's a tough point for people because a lot of times they want to leave that home to a kid or something like that. If you have a dependent, like maybe your husband's still going to live in the house, they won't make you sell it. But if you had to go live at Green Acres for 5 years, and Green Acres costs $5,000 a month, that's a lot of money. So the state, when your husband finally goes to sell the house or they pass, it goes to an estate, at that point, the state will put a lien on it, and they'll say, hey, we need to recover $55,000 for the cost of Betty's care. And then that's probably fair, right? That's your asset. And then, so I get asked that question a lot. People are worried about, what about my house, what about my cars? Stocks and things like that can be tough. A couple tips on getting through Altex easy. You can have somebody else on your bank account, like a son or a daughter, but don't have them use it, okay? Anything that's coming in and out of your account, you don't want your son dropping $50 here and there and then pulling money out to pay for the Verizon bill, and where it becomes really difficult for access to see where your resources are. You can have their name on it, but whatever that account is that they're looking at, it should be deposit, house payment, withdrawal for groceries. It's pretty straightforward. I've had some families have challenges because they're sharing an account and they've mixed their phone bill, and the daughter's paying for the car insurance and the mom's paying for the cell phone, and it gets really mucky. You want to get through that financial process as clean and clear as you can. Another tip: if you've got time and you've got family you trust, and I stress that latter point, Altex will not look at anything that has been in a trust if it's been there for 5 years. Okay, so if you have Wonder Son and he's not a dingbat or anything, and you put your home in his name, and it's there for 5 years in that trust, you can't make you sell it. Okay, if you do it the day before you apply for Altex, they're going to revert it. Okay, so don't waste your money on the lawyer if you're going to go try to create a trust. On the 11th hour, you got to get ahead of that stuff. And if it's all in the trust for 5 years, then you're good. What's the risk of that, though? What if that son or daughter has a drug problem, or they're not maybe somebody you can trust completely, they get in a bad way. You got to make sure that those assets can't be taken from you in that way. So there's a lot to think about there.
Would you like to close with the Alice story?
What's that?
Would you like to close with the Alice story?
Oh, sure. So we were talking about hospice being a personalized thing. We had a patient in this area who happened to, his wife had passed away. Did you mention it?
I did. May have a counselor in Sedona. Does May have a counselor in Sedona?
We have chaplains and social workers. The one of our team members that's more of a counselor is in Prescott. I'm trying to think here if anybody would really qualify for that. We have spiritual counselors and chaplains like Gary. We have social work. I think if you truly needed a mental health counselor, we would probably refer you to somebody, or I'd have to talk to the team to see exactly what the need was. It kind of depends on what the specific need is, whether that's something we would tackle or we would have an outside resource help with.
Do you go to Cottonwood?
What's that?
Cottonwood? Cottonwood.
Oh, yes, we have a Cottonwood office, yeah. Yep.
Do you have to go there?
No, we come to you in hospice. Pretty rare for patients. Every now and then they show up at the office, but not often. So this story with our nursing director, Alice, patient's wife had passed away in his living room. And when he got to the point of needing hospice, his wish was to lay on the floor in the exact place that she had passed until he passed. He was a Buddhist, and he had set up all of his things, his spiritual reminders and photos and everything in the living room. And he said to her, I don't want any medication that's going to interfere with my ability to perceive this experience the same way that my wife did. So he didn't want morphine, he didn't want lorazepam, he didn't want any antipsychotics or anything to deal with that. Alice was able to talk him into taking a little air mattress so he didn't get skin breakdown. But that's what he did. And his family and friends, he had a little cup of water, and but he didn't get up. He laid right there until it was time for him to pass. And I want to say, I think it took a couple weeks. I wish to know. Now they were still there to ask. But in that way, the reason I brought that story up to Gary is that it's very personalized. Okay, I can tell you all this stuff that we've talked about today, but your hospice experience is going to be whatever you want it to be, really. That's the way it should be. It's your journey. It's not something I get a second chance at. I can't, tell you, now try it my way, and if it doesn't work out, we'll try it again next time. It's not like that. We get one shot at this. So we're gonna do what you want. There are some boundaries there, right? I can't just say, well, give me 10,000 milligrams of morphine. I'm not gonna do that. But if you want morphine, we're gonna talk to the doctor about it. We're gonna talk about appropriate dosing, and if it's the right thing for you, we're gonna educate you about morphine. If you don't want it, we're gonna educate you on, you make sure you're making an informed decision. Here's what you might experience. Are you okay with that? And some people are. Some people have spiritually and mentally prepared themselves for that, like this gentleman had. And he had a peaceful passing. A lot of people come and support him and visit him, and he fed himself with those relationships and the satisfaction that he was doing something to honor his wife and sharing an experience with her that he, I think, wanted to have shared with her but didn't. And so he said, yeah, I'm going to go through it myself, just as she did. So yeah, it was, I don't think I would choose the same thing myself, but I get it. And so I think that's a big thing when you're asking about a hospice, asking them, can I do it my way? Here's what I want in this. I want to sit out on the lawn every day and look at the stars and sleep outside at night. Okay, well, I'm going to put your hospital bed outside. We got to figure out, what about the electricity? Well, if it rains, you better unplug it, right? Well, we may have to not use an air mattress because that's going to, could be a risk for you. But I actually had a Navajo family that did that when I used to live in Page. And you guys familiar with Navajo culture? Right, so depending on what your spiritual pathway is, you don't die in the home. That's a no-no. So this family took their grandma out onto the veranda area, and they set up some mosquito netting, and they pulled the TV out. They had the Xbox out there. They had a little coffee pot. The whole family hung out with her outside day and night, playing the TV, cooking, whatever. They did it all outside. They lived about 3 hours from any town, and so it wasn't like they could haul her into a facility or do that. She wanted to be on her land, and they wanted her to be able to pass there, but they couldn't do it in the house. So that's how we did it. They had a hospital bed outside and her oxygen tanks and stuff out there, and that's what they did. They had a little canopy for the rain, and so it should be something that you can personalize. Thank you guys so much for having me today. I was able to answer some questions.